So what we're going to do here is I'm going to challenge you to join me in making a commitment to yourself to do something. Not just sit here and let PowerPoint slides flick before your retinas, but take out a pen and write something down that you're going to do as a result of today. And use this opportunity to talk with leaders and experts to probe and try to find more information that would help you actually do something, not just something you're curious about. I will make sure that I will cut off any speeches that come in the form of a question, so make sure that they're actual questions. And with that, we've got a quick half hour. We got a lot of people, so let's get rolling. We've got mics around here. We've got some people that have written questions down in advance. I've got a short list myself. While we're waiting, why don't I just tee up one? I would be interested in and by the way, you can ask a question of the group. You don't just have to pick a speaker. I'd be interested in one or two people talking about the emerging or changing role of healthcare delivery systems in this social determinants of health topic. So, it's at the peak of the hype cycle. Our health system's supposed to hire 300 social workers and build, as we know, some health systems out west are investing in housing, all that. What is the role, what's the line of demarcation between a delivery system and the rest of the social service sector? And with the data spent, I'm going to ask you, because you've got a health system in your title of your job. So could you start with us? And I'm sorry, I forgot your last name. I apologize.
Hardcastle.
Yeah, thank you, Dr. Hardcastle.
I think you ask one of the most important questions, and I don't know that there is a good answer out there. But I think one of the challenges that we're seeing in our country right now is that we have set up unintentionally our health systems not to be able to address the core factors that influence health outcomes, which are the social determinants of health. And I think what you're seeing across the country is a recognition, particularly on the part of larger health systems, that is not the best way to address health outcomes. One of the things that I can say, which is depressing, I think, references a study that Harvard just published this past week, which is looking at the influence of value-based pricing for health systems. Because one thought was, well, as long as you have a fee-for-service model, then large health systems really kind of can't care about these other disorders because it's actually better for them to have sick people because then they can do a lot of things to the sick people and that's how they get paid. So let's switch the payment model and make them responsible for actual health outcomes, and maybe that will drive somehow these changes downstream or upstream, depending on how you look at it. And they've done studies and, more bad data. They show, sure enough, on a value-based system, there are fewer readmissions, which is one measure that people use to determine health outcomes. Unfortunately, what they discovered with this Harvard study is the reason there are fewer readmissions is not because suddenly health systems have gotten much better at addressing the social determinants of health, but there are fewer admissions into the hospital to begin with. And why are there fewer admissions? Well, what happened when you push this value-based system is then the hospitals, probably unintentionally, maybe intentionally, started treating healthier patients. Because there you provide less care and you get more money because they don't have to deal with all these complicating factors. And so all I can say right now is I don't think we have a good model for figuring out how to drive appropriate interventions in our society to address the fundamental drivers of poor health yet. Sorry.
Good answer. Yep. And the one thing the health sector has proven is the ability to make something 3 times as expensive as it historically was. So, if the, social work service and a health. Yeah. All right. Question in the back.
Hi, Teresa Baker here. I have a question.
Teresa, where are you from? Sorry.
I have 2 hats. I'm at Cincinnati Children's Hospital, and I have a company, Ignite Partnerships, which I've done a few things for quite a few people in the room.
Okay, great.
I have a question regarding the EMR. I have found that one of the biggest challenges to be that the EMR, quite frankly, is messy. It's intended to be used in terms of a clinical movement triage of capturing information and running information. And when you're trying to query anything in the EMRs, the data you get out is not, it's a minimum number, not a maximum number, right? You get the minimum that's reported, not necessarily the accurate number. And getting it updated accurately is unbelievably difficult. These are all clinical challenges that have to fall in a different sector. So when it comes to looking at data, I'm curious, the response I've had personally is to head towards the ICD-10 codes, because you're more likely to be able to query where the money's flowing, and you get a little bit better outcome generation. Was it Dr. Vendors? Yes. So how you guys were doing with the prison, your EMR systems that you guys are capturing and talking about and putting in interaction, are you dealing with ICD-10 codes? Are you dealing with ICD-9 codes? Are you dealing with, how are you building your own database, your measurements within your EMRs? Will they transfer to the other EMRs? These are all.
And great question, thank you. And
Yes,
as
sir.
you answer, maybe not just for ECW, which you guys used up there, but more broadly for the country, what you see.
Yeah, and ECW is no longer the EMR there, but we don't, when we adopt EMRs, especially in medium and smaller systems, we don't usually invest the time to plan out our workflows and think about what kind of reports and data we need out of them. And we picked that EMR in large part because the city had picked it because we were able to build our own reports. And so we knew that we could identify. So all the EMRs use the ICD-9 and 10 codes. People are getting diagnoses that are clinical diagnoses. We don't use the CPT codes, like we eventually started to, but that was not something we used initially. But I think that one of the reasons we used that EMR was because we could make modifications on the front end so that we could actually develop more structured data variables. So one of the human rights tool applications we used is to change how we took care of 2,000 people a month for injuries. So we put in structured data variables that every time had to be answered about not just where the injury was, what the severity of the injury was, but was your injury intentional? If it was intentional, was it a correctional officer? Was it another detainee? Were you restrained when you were injured? That ability to both on the front end and then produce aggregate reports on the back end that helped us was critical. And I think that, having been in a lot of health systems, I don't see administrations invest in engaging the staff who use the EMR clinically, and also the staff in quality assurance and billing to come up with a tool that's going to help them. I think that those are core problems every health system faces.
Next question.
So my question is also for Dr.
Can
Venters.
you introduce yourself?
Oh, I'm sorry. My name is Sarah Sommeler. I work for Prevention First. It's a local nonprofit in Cincinnati. So we see a lot of effectiveness with grassroots efforts in terms of substance misuse and mental health and food insecurity. But with incarceration and criminal justice being at such a systemic level, how do you suggest we as public health professionals go out and tackle those health gaps that you just talked about that exist?
For a long time, I thought it was with more data and better data. I think of the 40 or so peer-reviewed publications we produced, probably 2 of them mattered, or 3 of them maybe. I think that what I've found recently in the Closed Rikers movement, which has had great success, is I've thrown all my weight behind organizations that are led by people with direct experience of incarceration. So Just Leadership USA is a national organization, other local organizations that work, because when there is an opening for progress, and sometimes it feels like there isn't, when it is the message is and the data is presented by people who have felt the experience themselves, it is much harder for legislators or policy deciders to ignore it. And so the whole Closed Rikers movement for the last 2 years, I've really just caucused with Just Leadership. I'm behind them because they know what it feels like to have these health outcomes. I am just there as like a technocrat. And I think that that's my central message as Kentucky has a moment, or some hopefully multiple moments of reform coming, is to rally around all these resources here behind the people that have directly experienced these health outcomes, put their voices first, follow them, and it'll be much harder for any reform-minded or even like middle-of-the-road policymakers to ignore it.
What else? Who's up? Yes.
Hello, my name is Asha Clements. I am with Hamilton County Public Health in the Harm Reduction Division. And my question is also for Dr. Vendors. Thank you for your presentation. It was very informative. I just wanted to know, though, with Rikers closing in 2026, there's been obviously some things maybe that they've done wrong, but as you were talking about with their MAT program, they've done a lot of things right. And so I want to know, how is it possible for the things that they've done right to continue in the future?
I think it's transparency. I mean, New York City has a lot of resources, so it's not for want of stuff, of money, of staff. It's that we have to have health outcomes that are publicly reported. We have to have community involvement. So Legal Action Center, which is a national nonprofit that works in the space of harm reduction, they're out front, and the city would be terrified to run afoul of them, because everybody depends on the KEEP program, the methadone and buprenorphine program. So I think it's keeping the transparency open, and any efforts to pull back on transparency, I think should be seen as a mortal threat to the health of people who are incarcerated.
Yes.
My name is Amy Brown, and I work for St. Elizabeth Healthcare. Thank you all for being here. And my question is for Jessica. You talked about in your presentation that there are a lot of colors and different schemes that we use in our infographics and on our websites and whatnot that perpetuate and or contribute to, the disparities. Can you give a couple examples of those, or kind of those things that are just a high overview? Because I'm sure you could give a whole presentation on that, but.
Oh yeah, like the first example that comes to mind is I see when I see maps where we show the density of some disparity using darker tones, and if you're in a place like Kentucky or like Louisville where it's highly segregated, there's a correlation between skin tone as well as the darker tone for disparities. So we're continuing to reinforce like a lot of stigmas and stereotypes about those communities as well. Like it's a subconscious effect. Mm-hmm. So that's a good example, I think.
Interesting.
Does that answer it? Yeah.
We need more designers in the health sector.
Oh,
sure.
I wanted to mention too that the workshop, there is no level of skill that you have to have if you decide to go to the workshop on December 4th. I designed it to be a no-tech, low-tech sort of situation so that anyone can participate and gain skills. Sorry, a lot of people had questions about that earlier, so clarify.
What's another question? I've got a whole list, so. Yeah, front.
Hi, I'm Alex White. I'm with Louisville Metro Public Health and Wellness, and this question is also for Dr. Venters. We are working with a lot of community partners right now on a health impact assessment, specifically focused on expungement, and we were just wondering if you have like an ideal expungement policy, if you had to like dream up your best version of one, what that would look like.
I would be happy to connect you with my colleagues at Legal Aid, who have really led a lot of and Legal Action Center, who know much more than I do. So I wouldn't even opine on it. I'm not an expert on expungement, but there's lots of resources that I could connect you with.
Dr. Sadler, you and the crew that were part of the Build Health Challenge group, so by virtue of that, you were exposed to other communities doing cool stuff with health data. Do you see any emerging trends or clever merging of data sets across sectors that you think we ought to pay attention to in this part of the country?
Gosh, I think that the field is wide open. I really do. Once you start conceiving of how can we marry, like in this case, how do you marry healthcare system data with public health data with qualitative information from the community itself? I think that the possibilities truly are endless. And I think the biggest hurdle we've gotten over, which is the first time you try to do a data sharing agreement. And then from there, moving forward, it becomes and should become much easier. So I am anxious to look at a number of other public health priorities and start looking at how can we use it to not only hone in on where we should be working, but who we should be working with to address major health issues on sort of a micro level.
Great. Yes.
Teresa Baker here again. Dr. Sattler, I have a kind of a follow-up to that. I know that when the Build Collective was initially up and going, one of the items that we kind of looked into doing was talking with KHI. And at the time, I don't know if anyone in the room here is with KHI. If they are, that'd be awesome. I'd love to talk to you. But at the time, they were entering into phase 3 of regulating for the state of Kentucky to bring all of the EMRs together at the state level. And I kept thinking in my head that would have been an ideal solution for public health querying of the EMRs, because they've already got the first 2 stages done. At the time, there was only 3 people. Do you? I guess my question is, do you know if anything further has come from anything at the state level for KHI and Ohio? I can't remember what Ohio's is called, but it's like Ohio Health Informatics Exchange or something.
I don't, and there may be other people in the audience who do.
I happen to know that KI has a relatively new contract with Deloitte. Do you know, you're the Medicaid, what's the scoop? Are they doing anything or not? No, back here from Kentucky.
I know it's moving along, and unfortunately, the person in charge of it had to leave. But right now, it's free to join the Health Information Exchange from the state side of things. Unfortunately, EHRs, individual EHRs, are charging the doctors in their health systems lots of money to join it. So that's one of the barriers right now. So it's free on the state side, but if you're your own EHR or you're part of a health system, the larger health systems have joined. But if you have to do that, or a pharmacy, you have to work with your EHR vendor for that interface.
Another question? Matt, I got one for you. You have a pretty slick looking, at least on PowerPoint, information system at Ohio Medicaid. And yet your counterpart there in Kentucky talked more about different data systems that they're integrating across the Commonwealth. Can you say a little bit about your strategy to bring in other state data, or what would be your hit list prioritized of what data would be most relevant to achieve your policy objectives?
So in Medicaid itself, there are 900 different files that are consumed to produce information, and about 20,000 that are produced kind of outgoing to different entities. So there's already a lot of information that already is being consumed and distributed. But among the individual agencies on the IOP platform, so the Innovate Ohio platform, which is part of the Lieutenant Governor's initiative, most of the large agencies are already putting the data out onto that platform. And then for specific projects where we have data sharing agreements or data use agreements or specific governor initiatives, then we're joining those data sets together to then answer specific questions for certain policies. So depending on the nature of the project, there are several dozen different agencies that already have data joined together to answer some specific outcome questions.
And there's a different aggregator, not Medicaid necessarily.
It's out on the IOP platform.
gotcha.
So rather than each individual agency housing its own kind of black box, all of the security framework, the privacy, all of that's maintained at this state level platform.
Yeah. Cool. Yes. Introduce yourself, please.
Hi, I'm E.B. Saldana. I'm a doctoral researcher working here on Kentucky's child welfare system and aging out. And I actually had a question for Zach. So one of the things I run into with kids who age out is how highly mobile they are. They're really good at getting around cities, and I'm working mostly in Louisville. And I was wondering, you had mentioned on one of your slides about environmental contributors to health. It's like some 10% about like city design. And since we're talking about design and representation, I'm wondering how you track those kinds of environmental factors beyond, air particle, parts per million or whatever, and how city design might factor into anybody's sort of collections of data in terms of figuring out how to represent like where we live and its impact on how we feel. I don't know if that's kind of an abstract question, but
No, you're putting your finger on an important issue. We don't have great data about the physical environment and sort of how that impacts health. And then the data that I shared from the Health Value Dashboard is even less precise because we are comparing Ohio to the other 50 states. So for all of the metrics that we're looking at, we have to have that data availability from all 50 states. And we know that when we're looking at physical environmental factors, a lot of times it really is the neighborhood level information that matters. So unfortunately, I don't think I have a great response to your question, just an acknowledgement that this is a challenging area.
Hi, John Allen from CareSource Quality Improvement. And thanks everyone again. This is a great presentation, a great forum today. My question kind of piggybacks on what Craig asked about the health exchange for Ohio Medicaid, but I want to go back over to Dr. Theriault and the Kentucky and the Office of Health and Health Data and Analytics. Do you see some of that, is some of that information out there for public, for some of the stuff you presented today, for some of the reports you shared? Is that
Right
correct?
now, there are policy briefs up on the website, but you can't go in and do anything interactive.
Do you see that in the near term to be able to expand on that?
Yes.
Okay. Oh, okay. Okay. Thank you.
I'll make a comment while we're waiting on this. So part of the thing that the Health Collaborative does is we run HealthBridge, which was one of the first health information exchanges in the country. And it's for about 3 million lives in the greater Cincinnati region, up to date and down the middle of Kentucky. And so we move about 15 million clinical results a month, 10,000 providers, 10 large health systems. The little known secret about health information exchanges around the country is that they have less ambulatory data than you might expect. And a lot of the data is flowing from hospitals and labs to primary care providers. So all you pop health kind of fans, who want BMIs and all that stuff, that doesn't actually typically exist in a roll-up. It's becoming more the case. But so those data aren't just freely available. And whatever the question was, Ohio has 2 health information exchanges. Ohio Health Information Partnership stops at about north of Dayton, and that's where the Health Collaborative picks up. Another question all the way in the back. Home stretch, you guys. You can do this.
So to follow up on that point, I think this is a question maybe for a few of you. In the presentation specifically addressing the incarcerated population, are the Ohio HIEs, or can someone speak to the Ohio HIE or the Kentucky HIE working to connect to the state prisons? And are there any initiatives underway to obtain either CCD or ADT data?
Do you have a Kentucky answer?
We are working to connect to that system. There are, it's a completely separate system, so there are some problems, but we are working to connect to it, and we have different initiatives going to look at reentry, to look at look at making sure people have connections to their Medicaid and to providers when they are discharged. So those things are underway.
If I can just add one little thing, is when we connected to the Shiny, the New York Health Exchange, it was very clear that the most profound problems that people have who are incarcerated are often around behavioral health. So, that thing I mentioned, the psychosocial encounter, that's a big, huge, rich encounter that draws in all of the behavioral health and physical health problems a person has. That data is lost in a CCD. So these EMRs have been built in a way that, like, when we connected our things to everybody, we ended up with a lot of low-tech reentry on top of it, particularly for behavioral health issues.
Didn't you get LDLs?
Yes, critically important. Chloride levels.
Yeah. All right. A little nerdy back and forth there. Any other questions? So, to your point, and to just prove that I meant what I said about write something down and you're going to do, don't just sit here and enjoy the intellectual stimulation. My write down right here on a piece of paper, this guy will prove it to you, is explore how we can better connect locally to incarceration systems with our interoperability strategy, which is something that we've never done around here in this part of the country. All right. So who am I turning this back over to? Yep. You? Yeah, you ready? Okay. All right. Thank you all.
Please help me in thanking Craig and our panelists here, answering all your questions.